Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Yep, here we go again. So happy that you have elected to join us. You know, with all of the things you can do with your time these days, it's a matter of time to do anything. But I can tell you, we every week bring you new different looks at this condition, this venous condition about your veins. And we talk about a lot of things, but Dr. Juliff is the medical director of Vein Clinics of Hawaii on all 4 islands, and the website's great, interactive, and more things, including podcasts of this show, showing up there at veinclinicsofhawaii.com. So we invite you to go there and take a look at things, because the only thing we can't do on the radios is pictures, but maybe that's even going to change right now. Now our whole lives are on these smartphones. Why not? Why can't we video our stuff? Okay. Anyway, one of the things that I learned early in the piece is that the specialty of venous surgery or veins it's really a lot more organized than it used to be. In that there are the 6 stages of vein disease. And the object of the drill for us is to find out, for somebody once they are interested, where are they on the scale? Wouldn't that indicate not only how their condition is, but indicate how to get it treated? Right. Isn't that a big word?
Yeah. That is the case. We have a classification system by which we identify what the patient has, but also, as you allude to, how far along in the process they are, how severe it is, that type of thing.
Yeah, and the reason I say that is because I think almost everybody out there by now understands if you go to an oncologist and you go to cancer, when you see a story about somebody's in stage 4, they're at the end of. They're in trouble. I mean, stage 4 cancer is, and so I'm not saying that the same thing holds true for venous disease, but it's stage 6, which means it's broken out, over a longer period of time or severity?
I think probably both of those things, a fairly severe type of venous reflux that is now having a dominant effect on the skin and the entire lower part of the leg. But yeah, the classification system that we use for venous disease, I think, was modeled somewhat after the classification of malignancy. And but it doesn't have obviously the fatal repercussions that cancer does.
Well, I would imagine if you go to any vein specialist anywhere in the world that does at the level of treatment that you do and provide in diagnostics, that you almost don't have to know as a doctor, because you're going to be able to tell right away. But doesn't it sort of indicate, as you start documenting how I am, and I'm a patient, by the way, so I know a little bit about this, is that if anything ever happened, or if I was somewhere else, to get in the hold of my records will save a lot of time. Yeah. It's
a way for doctors to kind of communicate with each other. It's a way for us to know exactly where on the spectrum the patient is, and also it gives us an idea about how urgent our treatment should be. So yeah, and
no big deal. You got a little spider veins. No. We'll keep an eye on them.
Right. So yeah, the classification it's a fairly extensive kind of thing, but the section of the classification system that we use is most of the time is the clinical part of it, and there's physiology and the anatomic, etc. But so there are 6 stages, ranging from spider veins through varicose vein swelling, and then skin changes. And I was, the reason I wanted to talk about this a little bit today is because you can sort of where you put any one patient on that spectrum gives you a lot of information. Again, not only how they're going to be treated, but also or how urgent they should be treated, but also the final expectation. Because it kind of varies from class to class. And when I was thinking about this, topic in general, it seems to me that we get our best response or our best capability of treating a patient fully, kind of at either end of that spectrum.
Let me tell you, as a patient, I think there could be also stages of being a patient.
Yeah.
One is, okay, I got this thing, I checked it out, and the doc told me, well, these are superficial and they're not going to cause you any big issues. If you want them done electively, these little spider veins will make them go away. But I think the next thing is when, as a patient, when you start learning about what symptoms you are having and what that could mean, it lights the urgency button. It's time to go see the doc.
Yeah.
Or I don't want just elevating this leg, it makes the pain go away, but as soon as I stand up, it comes back. That must mean I need some kind of, I need treatment.
Right,
Yeah.
right.
So what my expectations of treatment are, and I looked at your notes and I said, hey, I love it. I came, I saw, I conquered, and it's healed.
Right.
And I don't have to worry about that particular vein anymore.
Yeah, exactly. Yeah. And we hope that those kind of symptoms prompt people to, seek treatment. And part of why we do this is to, try to educate people with respect to the symptoms of venous disease, because sometimes they're not very obvious. But yeah, so the C1, the first level of classification is C1, and that basically involves spider veins. And spider veins are the tiniest of veins. The veins in our legs, well, the veins all over our body, are sort of like a tree root, where the deepest veins are the largest ones, and they're carrying the greatest amount of blood. But as that root, or as that vein system moves out to the more peripheral areas of the leg, and obviously the skin is the most peripheral level, they get smaller and smaller, and so the tiny veins that we see on or actually in the skin, we call those spider veins, and I think most people know what we talk about or what we're talking about.
Let me tell you, I think this is really good and comforting for a number of reasons, and that is that, particularly here in Hawaii, and I do know that a lot of people get they get nervous, but once you sort of delineate what they are and which are serious and not, it dawned on me that the stuff that goes on way inside your legs and your big veins, you can't see most of that. So doesn't the other sort of very obvious things let a practitioner know this guy probably has, or this gal probably has something else we have better look at too.
It's fairly, after you've seen a lot of patients and examined a lot of legs, it becomes fairly intuitive by what you see superficially. And usually it's no surprise what we find out then thereafter, after we do ultrasound and we look at those deeper veins. That's how we evaluate function and get a kind of a snapshot of the deeper vein system.
Do you know that when I bump into listeners, one of the things that they always say, I forgot to tell you this last time we did a show, and that is we talk mostly about the legs. And a lot of people don't understand. Yeah, you have veins and arteries everywhere.
Sure.
But the problem is at the legs. That's the number one farthest apart from the heart. And all of this fluid goes down there. And if it can't come up, the troubles from in venous disease is almost always below the waist. Is that true?
Yes, it is. And that's
sometimes below the knee, for heaven's sake.
Well, the majority is below the knee, but and that's exactly right. We are, not only is it the furthest away from the heart, and veins carry blood back to the heart. So the blood in our leg veins have the furthest way to go, but it's also, that blood is fighting gravity.
Yeah, I should say.
Gravity, just by virtue of the fact that we spend most of our day in an upright position, gravity is trying to pull that blood downward, and, by a very intricate system of valves and, muscular activity, when the veins are working well, it's a very, very cool system, and blood does keep moving upward.
You know what I thought is also fascinating? I was reading somewhere, I think in your office, about animals. Animals on their fours. Yeah. That's like us, but they don't have, in other words, they can have front legs and back legs, all with problems. Because, But since we stood up, and now since we sit up a lot, right. Aren't we even more at risk? Sure. Because we are doing less with those legs.
Yeah. And that's kind of, I think, the turning point is when man became erect.
Upright. Homo sapiens, or whatever we call ourselves.
Yeah, exactly.
But interestingly enough, I think that getting into this, and I think when you talk about expectations, and a little later on in the program, I know because I looked ahead in the notes, I cheated a little. There are really ways that a patient can be participatory in what the expectations are. The more I learn as a patient, the more I say, is it time to do this? Is it time to do that? And sometimes when the planets line up, you just go get a procedure, and that particular part of your disease has been handled.
Yeah, and we have to be honest with respect to expectations. We try to be as honest as we possibly can with patients because they don't want to have a false impression of what we can do. I mean, we can do a lot of very, very good things with respect to vein function and even superficial things, but they sometimes. If the expectation is too high, then they're disappointed, but we can still make a tremendous impact. For instance, and spider veins are kind of like that. We never get 100% response, but we get a pretty good response. And if we are persistent and patient, typically we can do a pretty good job. But getting back to spider veins, what are they? We talked about that. They're the tiniest of venous vessels in our legs. They are in the skin, so it's not something that we can take out. For instance, with varicose veins, we actually take those out.
Remove them.
Remove them. We do phlebectomy, but on spider veins, they're part of the skin, so it's not like we can take them out. If we were taking them out, we'd be taking a part of the skin out. So, and we don't want to do that. Obviously.
Sounds painful.
Yes, that would be painful. So. And do they, people come in sometimes and say, gee, I feel like I'm having some discomfort there. Do they cause symptoms? Well, in my experience, sometimes I think they do. Unfortunately, it's still something that the insurance companies don't recognize as an adequate, symptom, and therefore usually spider veins are not covered by, insurance and Medicare. But still, I think sometimes they do. Now, most of the time, I would say no, they don't. But in a small percentage of people, I think they can create some achiness or throbbing.
Okay, so I've had a lot of the superficial spider veins taken care of.
Yeah.
So you say you don't remove them, but I can't see them anymore. So where are they?
Yeah. So the way that we treat spider veins is to do what's called injection sclerotherapy, and there's a variety of different medications in the past, and a lot of people have had this, in their past.
Sure, me too.
When they were treated. They were injected with saline, or what we call hypertonic saline, which is a concentrated type saline solution, and that caused the vein to collapse. We don't use that as much anymore. There's a couple of other medications that, number one, work better. Number two, are not quite as uncomfortable when you do the injection.
By the way, I must tell you as a patient, gang, that the treatment today of these spider veins and these injections that you're talking about, the minute you say that, people freak out and get all worried. I'm so amazed at the technology, the stuff you've shown me, Doc, how small these needles are.
Oh, yeah.
They're so small, and yet they're hollow because they're delivering the solution through them.
Right.
So you almost, sometimes, it just feels like you're touching. Like, it doesn't feel like an injection. Certainly doesn't hurt.
Yeah.
But didn't it used to? Or could it?
Well, well, you're right. The quality and the size of needles have obviously improved over the years. But I think more of it depends on the type of medication you're using because you're right. The needle going in, it's so small that the needle doesn't hurt.
No, the
when,
stuff does.
When
right?
when we do the injection, the medication can sting a little bit. Now, but that's only in certain areas. I'm always surprised how when we're doing injection sclerotherapy for spider veins, in some areas of most areas of the leg, it's almost painless.
Right.
But in specific
I was going to
areas,
say, as you get further down,
down by the ankle and foot, it's a little more uncomfortable, but also just in spotty areas around the leg, and sometimes it's just kind of unpredictable. But anyway, it's been interesting watching people. Injection sclerotherapy is what we do primarily. It's the gold standard still for spider veins of the legs. Are there other things out there that can treat spider veins? Yes, some people are doing laser therapy for spider veins. Now, I will say that laser therapy for spider veins on the face is a more effective way to treat facial spider veins rather than injection sclerotherapy. But for the legs, injection sclerotherapy is still the gold standard. And there are other things. There's a device that utilizes radio frequency energy and creates coagulation of the vessel. It's a fair bit more time consuming. It's a little more uncomfortable than injection sclerotherapy, as is laser. I mean, laser therapy for spider veins can be pretty uncomfortable. Yeah. And the recurrence rate for both laser and radio frequency or other modalities a little higher as compared to injection sclerotherapy.
Well, since we're calling today's program Expectations of Vein Care, I know that you can also drop in. In my case, for instance, I had some really horrific spider veins and varicose veins that are gone. I don't see any trace of them. Yep. And I do know that in a perfect world, they'd all be that way. But I do know also that part of the presentation you do as a doc is explain to somebody this is the intended consequence or result. But there are some things that are maybe either unexplainable or untreatable.
Yeah.
Or visually, they're not going to change that much.
Right. Well, what we tell people with respect to the expectation for spider vein therapy, what I tell people in general is that from any one treatment session, we expect about a 60% improvement in how the spider veins look.
Yeah, and that's really an honest an honest answer you give to people, right?
Absolutely.
What do I expect?
Absolutely. And, rarely or very, very infrequently, we might see somebody that responds less than that. Mm-hmm. I think fairly frequently we see people respond a little more than that. Yeah. But I think, about a 60% response is a good expectation for spider vein therapy. So what I tell people is, number one, it's never 100%. Number two, since it's never 100%, you might need more than one treatment session, which, many people choose to do. Then the next question they ask me then is, well, how many am I going to need? And the answer to that is, I don't know.
Who knows? Yeah.
Because,
however, I want to tell you that's happened to me, and one of the things that I found out that some of the results that you want, you just have to be patient. They happen.
Yeah.
But sometimes it takes a couple of months. Yeah. And then all of a sudden you say, hey, that thing's gone. Look, it's gone.
Right. That patience is a very important way to approach it. Patience is a virtue. So, and everybody's veins respond a little differently. Mm-hmm. Some people might only get a 40% response. Yeah. Some people get an 80% response. But so it depends on how the vein responds, number one. It also depends on what that patient is going to be happy with. Maybe we'd get a 60% reduction and that patient is happy, as opposed to another person who, no, they want 80 or 90,
And by the way, gang, sometimes the spider vein treatment is the only treatment that a patient will get. Mm-hmm. I mean, not everybody is going to be, umbilical to Vein Clinics of Hawaii's office for the rest of their life. Yeah. However, it's an elective choice that I've made, that once you know that you are susceptible or you have venous disease, you just got to keep an eye on it, just like any other condition, teeth, eyes, whatever.
Sure, yeah. So then the moving up sort of the ladder from spider veins is another vein that can be pretty superficial. We call that a reticular vein. Now, spider veins are tiny and typically they're reddish or sometimes bluish. And again, I think most people know what we mean by spider veins. There's a little bigger vein that's more bluish. It's a little deeper in the skin, and we call that a reticular vein. Now, do we treat reticular veins? Yeah, we do. Most people are not as offended by their reticular veins the way they are about their spider veins. However, reticular veins and spider veins kind of go together. Often that reticular vein, which is a little bigger, a little deeper in the skin, still we're talking very, very superficially, that reticular vein is actually feeding blood into the spider vein. So when we're doing spider vein injections, sometimes a fair amount of time we're looking for reticular veins that are kind of the feeding vessel, and we're trying to close those down too. And I didn't mention before that, the way that the medication works for injection sclerotherapy into any vein, whether it's a spider vein or even deeper veins, is that it creates inflammation of the lining of the vein, and that inflammation then ultimately makes the vein collapse, and then the walls stick together. So the vein itself is still there. It's just collapsed, and you can't see it anymore. Empty.
Right. And that's the part. Once I learned that, I thought, wow, this is really cool.
Yeah.
And then I also thought, and I think other you all listeners out there might think. And by the way, please avail yourself of the website. A lot of work has been done lately. If you have visited in the past, it's time to go back and take a look. You can see some before and after. You can talk about some of these pictures that we can see. But I always thought a reticular vein was one that went sideways. I didn't realize it was also an up and down. But I looked at it when you said it was like a ladder, that it looked like connecting all of these other veins. And I thought, well, if you take it out, then these veins aren't getting what they want anymore.
Reticular veins also are running sort of parallel with the with the surface of the skin, same way as spider veins. So the more superficial veins in general are arranged in that fashion. But there's such an intricate network of veins. Like I said, I keep kind of the analogy for me is a tree root, because there's just tiny little veins all over the place, and it's pretty easy for blood to get from one place to another. If one route closes, it easily takes another one.
For those that don't know, when we're talking about that, is it the same treatment for reticular vein as it is for a spider vein?
It is.
And are some reticular vein treatments insurance? Will insurance pay for some of that?
Typically, no, because
so this is another part. This is part 2 of the elective surgery.
Uncovered, but they sort of go hand in hand, reticular veins and spider veins. Although some people will not have a lot of spider veins, they'll just have very prominent, invisible reticular veins, and sometimes those people don't like the look of that, and we can do injection sclerotherapy, but that's still considered cosmetic and typically not covered. But so then the next question is, do reticular veins cause symptoms? And they kind of, I think, are under the same category in that way too, similar to spider veins. They don't, theoretically, they don't. But sometimes do I feel like they probably are? Yeah, sometimes I think they do. But unfortunately, insurance companies don't care. They still are not, covering it. And typically, that's sort of the division. Is there a disease process that's causing symptoms? If it is, then it's a medical problem.
And incidentally, but the way that bridged the gap with me was no question. When you get diagnosed, you get the initial consultation, which is complimentary. You find out where you are. And once you've done that, it's very, very clearly spelled out by staff and by the docs about saying, this is what you have, and here is a good, better, and best plan. In other words, everybody has to see everything that you do. It's customized to a specific patient's needs.
Yeah, sure.
That's unique in any medicine, I think.
Yeah. So, do we treat reticular veins? Yeah, as I mentioned, we treat them in a couple of different situations. number one, we treat them in conjunction with treating spider veins because it's important. You have to, in order for a spider vein to be treated completely, you have to get rid of that.
They're kind of operating in the same space, right?
Yeah, they are. Yeah. And also, more importantly, the reticular vein is feeding blood into those spider veins, so we need to close that down too to optimize the effect of our therapy on spider veins. And then sometimes in a post-procedural setting, when we're doing surveillance ultrasound, if there are larger, a little deeper reticular type vein, and if we feel like it's adding to potential reflux of the patient that may still be persistent. So reticular veins and tributaries of veins that we've already treated. Often we will use injection sclerotherapy to close those veins.
Yeah, and by the way, gang, that's totally spelled out. And once again, there's some before and after in regular veins, in the more serious conditions, which we'll get into later on with leg ulcers and that kind of stuff and skin. But this is sort of entry-level 101 as to what you can expect to be in the different stages. So this by far is the minor stage of all of them. The spider veins and reticular veins, mostly appearance. It's elective, but it does maybe create some awareness of symptoms. You said that it's not typically, they're not symptomatic?
If it's sort of a standalone kind of problem, there are people out there with venous insufficiency that also have spider veins and reticular veins.
Do some people think that the pain is those rather than what's underneath them that they can't see?
Exactly. And that's where it becomes a little confusing because people will come in and say, gee, these spider veins over here, they ache. They make my leg ache. So you never know. Is it a spider vein complex? Or is it underlying venous insufficiency, which many people have? So, spider veins and reticular veins, they are often a signal or a sign that the patient may have underlying venous insufficiency.
What I just thought about is, let's say, okay, I thought I was symptomatic because of these spider veins and reticular veins, and you treat them, they're gone, but my leg's sore.
Yeah.
So, obviously, that pain was not from those little veins that went away.
Right.
There's something more.
Yeah. And then, and it's, is that something more due to another unrelated problem? Is it musculoskeletal or other things that can happen? Or is it vein related? And that's a question that we do like to answer. Because in most cases, when people come in primarily with a complaint of spider veins and reticular veins that they can see, of course, we ask them about symptoms. If they have symptoms, we will, most of the time, we're going to do an ultrasound to make sure that there isn't any underlying venous insufficiency, because that's going to ultimately be important for their overall response, no matter what we're doing.
And that's why I love the next step, because the next step you're talking about is there's these spider and reticular veins, and then now we're going to get into vein disease and varicose veins. There must be good, better, and best of them too. Some that are not even a consideration. Don't worry about these now. But blah blah blah. These other ones need to be looked at. How do you differentiate, or does the patient get told about the stage, the different levels of varicose veins?
Well, you're right. Varicose veins are the next, clinical category up. So varicose veins means that the patient is now C2 classification. And, typically uncomplicated varicose veins means that it's usually associated with venous insufficiency. And that's what I tell most people, that if they come in and they have varicose veins, it's unusual to have just sporadic varicose veins the way that we can have sporadic spider veins.
Okay.
So, spider veins can
any area, a little here, a little there.
Can occur even without venous insufficiency, without underlying vein functional problems. Superficial varicose veins hardly ever do. They're typically, it's a pretty good sign that there is functional problems of the deeper veins in the legs. Something that we call venous insufficiency has to do with flow problems and valvular problems, etc. So basically, if people come in with varicose veins, we do an ultrasound in all those people. So again, it almost always indicates that there is underlying venous insufficiency, and with respect to expectations, uncomplicated varicose veins are probably the thing that we can eradicate the best, or the most, or the most efficiently, the most completely. What do we do for that? Well, we do we treat the underlying cause, the venous insufficiency, in the deeper veins that we can't see. And typically we're doing some sort of venous ablation for that. We've talked about that plenty on this show. And then we do what we call microphlebectomy, which is to make just little needle puncture sites through the skin, and through those puncture sites we extract the varicose veins. So the varicose vein is going to be gone. So I think in general, most people are, or patients in general, are the most happy with the fact that their varicose veins have been eradicated pretty completely.
Yeah, and gang, because I've had these procedures. There's one thing. Sometimes this varicosity or whatever, it's not just an inch long. It can be real. It can be from your knee all the way down. And I've noticed some of the treatment that I had was every so many inches, or every so much space, you go in with the needle and you take that little piece of the vein out, then you can get the next one. Right. So they don't come out like a big long spaghetti.
Yeah, unfortunately they don't. That'd be great. But we kind of march up the leg, or march along the path of the varicose vein, and it comes out in segments. But it works very well, and we are able to usually accomplish complete removal of that varicose vein. Now, are there potential complications? Sure, there's complications, just like in any procedure, but the complication rate is very, very low. The things like bleeding, infection, bruising, healing problems, those kind of things can occur again, as they do in any other surgical procedure. But it's very, very rare.
And let me tell you what's really cool about this is when you've had a procedure, and I've had many, is that you get this little list. Here's a list of what to look for over the next couple of days. Pretty even. I mean, with the amount of experience that you and everybody has, and sure, something can happen, but it's not. You're the only person in the world. It's somebody's been there and done that. There's even a way to get that treated.
Sure. Yeah. It's by and large, everything that happens we've seen before, and there's a proper way to take care of it, and it's typically not a big deal. But and then there's another situation that sometimes comes up is when patients are on blood thinners, and do we want them to stop the blood thinner to do these types of procedures? Well, no, we don't really even need them to stop their blood thinners.
But knowing this is good, though, right?
Knowing, we have to know it, and might that patient have a little bit more in the line of, ooziness, bleeding, bruising? Yeah, they might, but all of that, resolves with time. Infection is very, very rare. When we see it, usually it's in people who have other medical problems like diabetes, and maybe more elderly, et cetera. So there are patients that are a little higher risk for infection, but it's pretty rare. The main thing is discomfort. I think sometimes, and when we try to manage that expectation too, some people have a little more discomfort than they think they're going to, and I think it can be a little deceiving the way that we do things these days. If somebody goes into the hospital, goes into the operating room, has a bunch of incisions on their legs, et cetera, and they have some discomfort post-op, that makes sense to them. Their brain is okay with that. But we do things so minimally invasively anymore that people, I think, afterward look at their leg and they say, "Gee, I don't. It doesn't look like we've done much of anything."
Oh yeah, I've heard that and seen that, and the really cool thing about it is that it just doesn't stay like that.
Yeah.
I mean, you just have to have faith. Doc said it's going to go away, but it's a week. It's worse. No. It's sometimes, isn't that funny?
Yeah.
Like it looks like it gets from a blue bruise to a yellow thing. Then, oh man, this is never going to go away. Then one day you wake up and say, where's that thing?
Yeah. Yeah. All of those post-procedural kind of things. And it's all a healing process.
Sure.
You know, everything that we do essentially creates inflammation inside the leg. That's how the procedures that we utilize, that's how they work. So sometimes it takes a little while for that inflammation, that inflammatory state to sort of resolve. And some people do it a little quicker than others, but so there's a little bit of discomfort. But typically, it's not a great amount, and most people, find it tolerable. Certainly. So So in general, the expectation for varicose vein treatment is pretty good.
Right.
You know, I mean, we do a pretty good job with that, and the methods that we have are very effective with eliminating varicose veins, not only for cosmesis but also for symptoms. You know.
Yeah, and incidentally, friends, if you go to veinclinicsofhawaii.com, you'll see some of this stuff. But when you start feeling better and you can do more things because the pain associated with the condition that you've had treated go away, that's when you really get the value of discovery that you did, going to the specialist that you are, getting the procedure and saying, wow, I don't mind people looking at my legs anymore.
Yeah.
I'll go play tennis with you, sure.
Oh, yeah.
I won't wear jeans.
Right,
You know?
right, sure, yeah. Okay, so the next classification up from varicose veins is swelling, and that's the C3 classification, and definitely it's one of the symptoms of venous insufficiency, one of the symptoms and signs. And why does swelling occur in general? Well, one of the reasons is our vein problems, but there are other things too. There are metabolic problems that can lead to swelling in the lower extremity.
A bunch of fluid down there. That's kind of something attached to swelling, right?
Sure.
Yeah.
Heart and lung disease, chronic heart and lung disease often can lead to chronic swelling in the legs. And then something that we talk about all the time is something called lymphedema, which has to do with lymphatic fluid flow which goes throughout our entire body, but it can be problematic in the legs, and it also kind of goes hand in hand with venous insufficiency. So there are a number of other reasons why swelling occurs in the legs other than just venous insufficiency. So our expectations have to be a little. We have to be cautious in our expectations with respect to, our prediction of how fully any one person's swelling is going to be resolved once we fix their vein disease.
Yeah, I'm glad you said that, because I do know that a lot of times a primary care physician that is faced with swelling, sometimes it's dermatology, sometimes it's vein, sometimes it's this or that. So this is where they're acting as a quarterback. It's important, because isn't that a major part of the elimination process that you all go through to determine, number one, what does this guy or gal have, and then what are we going to do about it?
Right. Yeah. And like many symptoms, and swelling is one of those symptoms that, since it has a number of different etiologies. Sometimes we have to eliminate them one by one. If we find that a patient has venous insufficiency, then we're going to address that. Well, we might be doing that while the patient is, being looked at by other physicians with respect to their heart function, lung function, kidney function, et cetera.
It's like when you look at the patient in your book, well, which of my guys have I seen today?
Yeah.
Maybe, a twofer. Maybe it's a good idea to see. And I know that happens a lot, right? Sometimes, since while we're at it, if a dermatologist decides that skin thing that he's been treating isn't a skin thing, you got to go see Dr. Julep. You got to go to the vein clinic to get that fixed.
Right, yeah. And we all do that. We treat things and see where it takes us, not an illogical way to approach a problem, sure. So, why does swelling occur in venous insufficiency? Well, it all goes back to the fact that, veins should be carrying blood upward in the legs, and one of the ways that the veins do that is by these one-way valves. Those valves can fail for a variety of different reasons, and when the valves in our veins fail, then the blood starts to go downward, and it just from a practical standpoint, it would make sense that obviously that fluid moving downward is going to create swelling in the lower extremity.
Can that be sometimes a pretty big amount of fluid?
Yeah.
Yeah, I mean,
sure.
In other words, if your legs are swollen and when you press your skin, because I know I used to have, worse edema than I do now that I've been treated, is that sometimes you would press your thumb into that area and it'd stay depressed.
Right.
And that meant a lot. Sometimes I think you even told me there could be 5 or 10 pounds of extra fluid down there. Easy.
Yeah, the veins, the way that the veins are constructed is that the walls are thin and the veins can expand quite a bit. Mm-hmm. So
so if the blood can't go up, it just sits there and expands.
Exactly. And we refer to that as the capacitance. What is the capacity of the venous system, especially in the lower leg? Well, it's huge. And like you said, it could easily be 5 or 10 pounds worth of not only excess blood but fluid that has accumulated in the lower part of the leg. So after we treat, along the lines of expectations, after we treat somebody's venous insufficiency, do we ever tell them, oh yeah, we're going to eliminate all your swelling if they come in with a primary complaint of swelling? Well, no, we don't, because we rarely can actually do that. How much swelling is going to resolve after we treat people? Obviously, it's going to depend on how much of their edema is due strictly to chronic venous insufficiency.
Got it.
And again, much of the time there are other issues going on, especially lymphedema. And we'll talk more about that in 1 second.
In the meantime, though, I do want you to remember this, to go and see the website, veinclinicsofhawaii.com. We don't usually give phone numbers and stuff. It's better if you go to the website. Phone numbers are all there, depending on which office you want to go to. But you will see, and you'll be able to put yourself in these pictures. I think that's one thing about it, Doc, that, you're getting enough stuff up there and some of the podcasts and some of the other things. That it's a nice little stop. If you got conditions, go check it out. veinclinicsofhawaii.com.
Yeah. So, if somebody comes in with swelling and we find that they have venous insufficiency, and maybe we might think that, there is something more going on here. Maybe they have lymphedema, maybe they have some chronic heart disease or whatever. Is that going to stop us from treating their vein disease? Well, no. We still, go ahead and do that. Why do we want to do that? Well, in general, we want to eliminate venous insufficiency as a cause. So we want to kind of take that out of the equation. It's, the procedures that we do are, very low risk and easily accomplished. So we want to basically optimize the function of that extremity in general. And, one of the ways that we can do that easily is by treating their venous insufficiency. So, like I mentioned...
Is it that simple? Yep. I mean, in my case, it was.
You're right, yeah. So again, getting back to lymphedema, and lymphedema is, kind of goes so hand in hand with venous insufficiency that even many people in those lower levels of classification, even people with just varicose veins, often they will have some, albeit a small proportion, but some amount of lymphedema that is sort of being generated with time. So lymphedema is a constant thing that we think about and have to go about treating too. So we eliminate the venous insufficiency by doing the procedures we do, and then we address lymphedema. And like we've talked about in the past, lymphedema is treated primarily by mechanical things like compression.
Incidentally, by the way, once you are able to identify and categorize where you are, what you are, it's not sometimes a matter of it going away. Doc said before that there's not really any any duck soup way to take care of lymphedema, but you can manage it. And that's the key, isn't it? Being able to manage it. And like you said before, here we go again with compression socks. Just by that, the condition that I have is greatly reduced because my legs used to be swollen, and bottom line is they're not anymore.
Right.
Because of compression hose.
Yeah. Compression stockings. And elevation. I mean, most people don't think of elevation as a medical treatment, but in this case,
isn't that funny? Because
really
it's kind of automatic, isn't it? I mean, our head
often
says,
it is.
Yeah.
When people, put their legs up, their legs feel better. They get smaller. Yeah. So again, we want to optimize the overall process of what's going on in that leg. And then, even after we fix the venous insufficiency, is that patient still going to have to deal with some amount of swelling? And should they continue to treat it in some way? Well, yeah. In that we have the most difficulty trying to get patients to, follow through with that.
I got to ask you this. Somebody asked me specifically, heard us talking about elevation and says, well, I have a recliner. And so it really feels good when I get on the recliner. And I thought to myself, okay, I went through that, and you told me, yeah, recliners are fine, but they're not. I mean, even laying flat is better than being on a recliner because I don't care how the recliner works, your feet are usually below your heart, and that's not what you want, right? Elevation.
Right. Elevation, it's a tricky thing. Probably we would get the best result with elevation if we were hanging, upside down by our feet.
Yeah, like a piece of meat. Right?
That would be the best way. Obviously, that's impractical. So, what I tell everybody is the best way to elevate your legs is to lay flat on the couch or in bed or whatever, wherever it's comfortable and convenient, and then get your legs up on 2 or 3 pillows.
Yeah, my wife says, "I'll go make your mountain." My little cushions up there.
Yeah. So the important thing the couple of the important things are number one, like you say, to have the legs above the level of the heart. Whatever part of your body that you're trying to drain of excess fluid needs to be above the level of the heart. So if it's your legs, it's your legs. If, sometimes people have swelling in one upper extremity, one arm. Well, we need to get that arm up above the level of the heart.
Wonderful treatment, by the way, isn't it?
It is.
But here there is a downside for me. And you can explain this. If somebody just elevates and thinks that they're doing everything they can, they've elevated. All of the good that elevation does goes away once you get back on your feet again, because all of that fluid says, "Oh, good, I can go back down there." Yeah, it just falls down.
Right. So, it's a tricky kind of situation. I think ideally, when people have chronic swelling, the thing to do is to first thing in the morning get those stockings on. Most of the time, people with swelling, unless it's sort of an advanced stage of the overall disease process, much swelling will resolve overnight just with the patient laying flat. They don't even have to have their legs elevated. But if you sleep for 7 or 8 hours and your body is flat, there's going to be a fair amount of resolution of the edema in your legs. And so the key then is to, once that swelling goes down, then to put your compression stocking on right away, and that compression stocking will, keep it in check and hopefully not allow it to reaccumulate, over the daytime hours. But elevation is something that we kind of put in, schedule into the patient's, day in whatever way is convenient. If they could, elevate their legs for an hour or so in the afternoon, middle part of the afternoon, then that's going to be of benefit.
It's a great tool. I mean, once you start doing it, and I said that, sort of semi-jokingly earlier, Dr. Juleff, and that was that I think in many respects it's kind of automatic. I think it's been the universal, do this, you'll feel better. And it really does. Isn't that why sometimes when you finally get into bed at night, think, oh boy, I love this place.
Yeah.
There you go. Makes you feel good. Do it.
Many people do automatically elevate their legs at the end of the day or whenever, because it makes their legs feel better.
Can elevation ever be a bad thing?
I don't think so.
Yeah, that's good. We're going to remember that. When in doubt, elevate.
Yeah, you can never elevate too much. But it's kind of a learned response. People don't know why they're doing it, but at the end of the day, they go home and elevate their legs, and it makes them feel better. So then the next tier is what we call C4, classification stage 4, and that's when we start to have problems with skin. And the changes in the skin, either color or texture, show us that the patient has had venous insufficiency for a relatively long period of time. It's getting into a more severe stage. Definitely needs to be addressed. So
we joked about some of the things as we get up to this point, but now the joke part's done.
Yeah.
Now we're getting to a serious condition that you may have, and once you find out what a symptom is, and once you get it looked at, you're going to start feeling better. And patience is a virtue, but don't wait.
Right. Yeah. So, with respect to skin changes, the first thing that happens is pigmentation, darkening of the skin.
Color.
And that's one of those symptoms and signs that most people don't know is even related with venous insufficiency. So we try to educate people all the time. It's so often people think, well, it's the lower part of my leg. It's the most exposed to the sun. Or a lot of people feel that the discoloration of their skin is due to diabetes, etc. But often it's due to venous insufficiency, and probably it needs to be looked at. So why does that happen? Well, it happens because, again, blood starts to accumulate in the lower leg. The blood starts to go in the wrong direction, and this leads to something that we refer to as venous hypertension. And what does that mean? Well, that just means increased pressure in the veins that is ultimately transmitted out to the surface, the periphery, the surface.
We've talked about that before, Doc, and that is every now and again you get this thing you call a bleeder. I mean, that's just where it just lets loose.
Yeah. Well, that's one of the complications. Definitely, we see that periodically. But what happens is that the pressure within these tiny little veins actually exceeds the vein's ability to contain blood and fluid, and fluid starts to leak out of the veins and into the subcutaneous tissue of the skin as well, or of the leg as well as the skin. And along with that comes pigment molecules, which can be a part of the red blood cell, and then also other molecules and stuff that create an inflammatory process, and so that all leads to not only brownish discoloration, but as the process goes on, the skin becomes thickened and irregular and rough. That all happens for a variety of different reasons. But unfortunately, with respect to the expectations of response or response after treatment, we don't get as much of a complete response as most people would like. Pigmentation in general is not going to go away. Sometimes it lightens up a little bit. As we go through that level, that C4 level, then the skin starts to become even more diseased, and that leads to something that we call lipodermatosclerosis, which is something that we get very, very concerned about because the next step is ulceration. We don't want that, and unfortunately with pigmentation and also those advanced types of skin changes, the ultimate result is not as complete as we would like it to be most of the time. But the important thing is to stop the process so it doesn't get worse.
Yeah, and that's where we're gonna have to leave it today, only because the stages, of the 6 stages, this is the most important one. Once you've got to this, if you're this kind of a patient like I am, you really need to get a hold of what's going on. And I invite you to not only come back and see us, but you can go listen to the podcast and everything by going to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. And particularly, if you want to see some stuff that is important. I think the value here, Doc, is to make sure that a patient knows, and I know that you've told me, and I'm assuming you told everybody, of the 6 stages, here's where you are, my friend.
Yep.
And this is the management that we need to do to keep you right there. Let's not let things get worse.
Right. And one other thing about the website, Mike, I just wanted to mention that we do have a link for people who are listening to the recorded programs where they can go in, jot down a question if you have it.
I love that.
We'll get it, and then we'll talk about it on the radio.
It is all high tech, and we do that. As a matter of fact, we welcome your input. Because you're listening to the show, we'll let you know it is recorded. Every now and again, we're on in my regular morning show, and we'll tell you about that too. But in the meantime, go get checked out and become a much happier person. Remember, if your legs are healthy and happy, you will be healthier and happier, and that, my friends, is a guarantee.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, VeinClinicsOfHawaii.com. That's VeinClinicsOfHawaii.com.